Hello, good evening, and good day. It's good to be back. It's 8 p.m. UK time. So, as you know, it is time for our IVF webinar. It's good to be back, and thank you already to everyone for joining us once again and for your questions in advance. So I always am happy to hear from where you are, and if you would like to also let me know that you can hear me, let me know. That would be perfect. And also, I just want to mention, as always, that today we have another very interesting topic and that we will discuss, and also two very special guests. I am very happy to have you with us. So there is Melissa and also Dr. Lavi. Hello to you. How are you feeling? How is your
Hello.
day going
Good.
so far?
Hello. Happy to be here. Thank you for having us.
Thank
Yes,
you so
very
much.
good to be here.
Thank you so much. We are definitely happy to have you with us today as well. And first of all, let me just remind everyone that we are gathering here every single day from the very 1st of April, and we will be continuing with those events until the end of June. As you know, there are plenty of topics, and there were also plenty of experts involved in all of those Stronger Together events. But also, I want to thank to our ambassadors and partners. As always, without their assistance, without their help, it would be very difficult to create such events. So again, thank you for their support. And as I mentioned, today we do have another topic that we will discuss, and it is surrogacy and egg donation, the US experience. So we have two presenters, as I've mentioned. So that is Dr. Gat Levy, and that he is also he is also the medical director and founder of New England Fertility, located in the US, Connecticut. And also there is Melissa. She is actually cooperating with New England Fertility, and she will also present her presentation on surrogacy from the legal point as well. And as always, just let me remind you that we will start with the presentation from Dr. Levy, then we will go for Melissa's presentation, and after that, as always, there will be time for your questions. So please remember to put the questions in the chat section so both Melissa and Dr. Levy can help you out with any questions that you have. And that is it from me at this point, but of course I will be back during our Q&A session. So thank you already, Dr. Glavi and Melissa. And are you ready to begin?
We are ready.
Excellent. Thank you so much then, Dr. Levy. Go ahead.
So first, I'd like to thank Carolyn for organizing, as usual, very well organizing this webinar, and of course all the attendees. I think this is a great opportunity to learn about this topic. And I'm very happy to have with me attorney Melissa Brisman, who is one of the pioneers of surrogacy, reproductive law and surrogacy in the US. So my name is Dr. Levy, Gad Levy. I'm a medical director of the New England Fertility Institute, which is located in Connecticut, in Stamford. We're a fertility IVF clinic, but our focus, our passion has been what we call third-party reproduction, which involves egg donation, surrogacy, or both. And as you will see during this presentation, this is a team effort. It's not something that one person or one clinic or organization can do by itself. And that's why it's so important to have a good partner in this, and we have one in Melissa. So we work very closely together to help our clients, our couples or individuals achieve their dream of having a baby. So what I would like to do for my part is go a little bit over the medical process, explain how that works. We'll talk about the IVF process, which is essentially the basis of what we do. And we'll talk about the different components We sometimes use an egg donor, sometimes we don't, and we often use a surrogate. So I'll try to explain from the medical perspective how we evaluate, screen the donors and the surrogate, and how we perform the medical procedure. You see the highlights of Melissa's speech, and she will focus on the legal aspects. The agency usually will find the surrogate for you. Once we do the screening, the medical and psychological screening, we will do the legal arrangements. Melissa will do the legal arrangements, pre-birth order, and she can explain all those things to you. So let's just start and move to the next slide. And the next one. So I will have that, you will have that information available, and I'm more than happy to contact with you and have a consultation or a call with you to review your particular case and see if we are a good fit to help you. So just putting it very simply, I mean, the medical process, as I said, is IVF. And of course, very simply, to have a baby, we need to have sperm, we have to have eggs, and we have to have a uterus. And what the IVF process does, it essentially puts all these things together. So the sperm, of course, can be a partner sperm or could be donor sperm. The eggs can be your eggs or donor eggs, and the carrier could be your uterus or the surrogate. So in this talk, we'll focus more on the surrogacy process. But as you know, all these permutations, all these combinations are available. And, I feel lucky to be able to offer all these different options because, of course, everybody has their own story. Everybody has their own issues. And by having all of this, we can help almost everyone. We can help couples, heterosexual, same-sex couples, individuals, male, female. So pretty much having those options allows us to expand our clientele. As I said, what stands in the center of the medical process is in vitro fertilization. And in vitro fertilization is a procedure that has been around for not that long, actually. The first IVF, in vitro fertilization baby, was born in the late 1970s. And since in vitro fertilization came onto the scene, it basically revolutionized the treatment of infertility. Since the inception, to date, there are about 10 million IVF babies in the world. So, of course, that's become one of the primary methods of treating couples, individuals who are trying to have a baby. And very simply, this is the process. We use ovulation drugs, fertility drugs, for the woman to produce multiple eggs. Normally, a woman would produce one egg. In a stimulated cycle, a medicated cycle, depending on the woman's age and her history and her hormones, we can expect to get somewhere between 10 and 20 eggs. So this first part, the first step, is called the ovarian stimulation. Once the eggs are mature, developed, we proceed to what's called the egg retrieval, where we harvest the eggs. You can see here a picture of an ovary that has multiple, those dark spots are the follicles. These are where the eggs are growing. And with a very simple procedure, which is done through a vaginal ultrasound, you can see the little needle here goes into this follicle with the egg and pulls the egg out. The third step is once we have the eggs and we have the sperm, we create the embryos. So the egg becomes fertilized, becomes an embryo. We let the embryos grow in the laboratory for usually 5 or 6 days to allow us to actually identify the stronger, more viable embryos, and also allows us to do some genetic testing on the embryos to make sure, make sure that the embryo that we eventually pick to put back into the uterus is the right embryo. So as I'll show you in a minute, the way we do the process today is after the embryos are created, grown for 5 or 6 days, and genetically tested, we will freeze the embryos and keep them frozen until such time that we have a surrogate who's ready. We make sure the surrogate is tested, screened, prepped, and then when she's ready, we will usually throw one embryo and place it into the surrogate's uterus. So this picture basically shows you how the procedure is done. We have an egg, we have an embryo or fertilized egg. We call it a day 1 embryo. Still one cell with 2 nuclei. And then we continue to watch the embryo grow. So by day 3, it has about 6 to 8 cells. And by day 5 or 6, it has about 200 cells. So the embryos grow really, really quickly. And by day 5 or 6, we have what we call a blastocyst. And this embryo not only has so many cells, but also, as you can see in this picture, has 2 distinct parts. One part is what will develop into the baby, that clump of cells on the bottom. It's called the inner cell mass. And the other part is what will become the placenta, all these other cells on the periphery. And this allows us then to do genetic testing and essentially take a few cells from the part of the embryo that will become the placenta and do some a genetic analysis. And that way we know that we're not affecting the baby. So essentially, this is the creation of the embryos. We usually start with an egg donor with about 20 eggs, and I'll show you in a minute. And when we're done with the genetic analysis, we usually end up with about 6 to 8 genetically normal embryos, but each one of those embryos has a very, very high chance of success. This slide demonstrates why we like to do the genetic testing, and actually why we like to take donors who are young. Because the younger the person, the younger the woman, the more likely she is to have normal embryos, genetically normal embryos. The reason we do it with egg donors is that even with egg donors, those are young women who have been carefully screened and tested. There's still about 30 or 40% of their embryos that are genetically abnormal. So again, by doing the genetic testing, we're able to pick one embryo and expect to have a very high chance of success. And just to summarize the process and the 2 parts, the first part is the embryo creation, genetic testing, and freezing. So the egg donor goes on the medications, the eggs are harvested, the eggs are fertilized to create embryos, the embryos are grown, and then genetic testing is done and the embryo is frozen. So at the end of the first part, we have a frozen embryos, and each one of them has their own genetic profile. So we know if it's normal and abnormal, and of course, when you do the genetic screening, genetic testing, you can also identify the gender, so you know if it's a male or a female. So in order to do the first part, you need to have the eggs and you need to have the sperm. And depending on where the sperm and the egg comes from, obviously we will organize the process to make sure that we can get started. Once the eggs or the embryos are frozen, they can stay frozen theoretically forever, but definitely without any effect on their viability. So usually we complete the first portion of the process first, and then have the embryos waiting for the surrogate to come along. So when we find the surrogate, screen her, do all the testing, prep her with hormones, when she's ready, we usually will take one embryo out of the freezer and do the embryo transfer and expect between 70 and 80% success. So as I said, the reason we do all these testing is so we can have that one embryo that has a high chance of success. We generally prefer to transfer a single embryo in order to avoid the risks that are associated with twins. For some couples, for some people who are very interested in having twins, we can discuss having 2 embryos transferred. Of course, the chances of having a pregnancy, 1 or 2, is very high, and there's about 60 or 70% chance of having twins. So I always say, I mean, sort of point people back to this to this table to show them that unless you really want to have twins, you should only do 1 embryo. So it's really not worthwhile to transfer 2 embryo just in order to increase the chances of success if you're not interested in having twins. And this is a conversation that we always have. The chances of success, the risk to the mother and the baby, and the cost. So with IVF in general, and particularly with surrogacy, we basically come back to this discussion several times during the process. And as Melissa will explain, if you have your mindset on having twins, we will find a surrogate that is not only willing to carry twins, but also someone that we think medically is able or with a reduced risk. Going back to the different components of the process, we start with sperm. That's usually the first thing. The first step is to obtain a sperm sample. So whose sperm do we use? For a heterosexual couple where the male partner has normal sperm, of course we will use the partner's sperm. When we have a same-sex male couple, very often the partners would decide to split the eggs and fertilize half with one and the other half with the other partner, but it doesn't have to be that way. It's a decision that we make. And if we're working with single women, we of course usually use donor sperm. So no matter where the sperm comes from, we of course make sure that the sperm is normal. Once we determine that the sperm is normal, the sperm sample will be frozen. And at the same time, we will do all the regulatory testing that are required in the US in order to work with a surrogate. And we call it the FDA testing, but really it's a panel of infectious disease testing that has to be done in an FDA laboratory within a certain time of when the sperm is given or when the eggs are given. It's a sort of a formality, and actually this whole process for Europeans, we usually can arrange for the sperm to be frozen in Europe and all the testing be done in Europe and then shipped to the US. So, we can talk about the logistics later, but it's not necessary to come to the US, especially these crazy times, just to give the sperm sample. As far as the eggs, of course, if the female partner or the woman has normal ovarian function, we can use her eggs. We use egg donors for women who don't have good ovarian function, and of course for same-sex male couples. We'll have this discussion, this conversation during the consultation, exactly what is the right solution, what is the right way for you to do it, and then we make the plan. When we use an egg donor, of course, we're looking for women who are healthy, very healthy, and also women who have good eggs. So one way to do it, to basically just a very initial screening, is to take women who are young. So we always have donors who are under the age of 30, mostly between 20 and 28. We make sure that they're physically healthy, we make sure that they're mentally healthy, non-smokers, no drugs, good family history, and good ovarian function. And of course, as part of the process and the screening of the donors, we always want to make sure that they're doing it for the right reason, because we also worry about the donors, making sure that they don't do anything that they will regret down the road. So we spend quite a bit of time on the psychological as well as the physical assessment of the donors. So very briefly, the donor goes through a medical evaluation where we test their ovarian function, health survey, infectious disease testing. We do a very thorough psychological evaluation where they would meet with a therapist and also have a written personality assessment test. That's a standard test in the industry that basically allows us to identify all kinds of pathology. It's called the PAI. So like I said, we do a lot of psychological, we do even more genetic screening, genetic testing. They meet with a counselor, they create a family tree, and also we check for recessive genes. So we call it carrier screening to identify whether the donor is carrying any abnormal genes. And with all the advancements of technology, especially in the field of genetics, we can now test for about 300 different genes and make sure that the sperm and the egg donor and the sperm donor are not carriers of the same abnormal gene. That way we can be sure that the baby will not be affected with that condition. The egg donors can come in different varieties, I would say. And one of the advantages of egg donation in the US as compared to Europe, for instance, is that the parents can actually get a lot of information about the donor. Up to a point that if the couple is interested in meeting with the donor, either in person, on the phone, on Skype, or exchanging email, that's also possible. So the donors that you will see in the US, you have a very, very detailed profile with information. You'll have pictures, so you'll be able to actually see what the donor looks like as a child and currently. And also you'll have to decide if you want to have any kind of connection with the donor. And that's a very personal decision, but that option is available, and we can talk about what option is better for you and what advantages or disadvantages each one of them have. Some of the donors have actually donated before. In the US, there's really no law that controls that, but mostly the guidelines that we have that the donor donates no more than 6 times. We try very hard to make sure that once the donor donates, for example, in Europe, if she donates in a certain country, that she won't donate again in the same country, just to basically reduce the risk or the possibility that the siblings can meet. But essentially, some of the donors that have donated before, some people think that they're better than donors that are doing it for the first time. But the purpose of actually bringing up this slide is to tell you that there is no difference, and that the success with a first-time donor is just as good as it is with a proven donor, which allows you to actually have a wider selection or wider to choose from. In most cases, the process goes according to that diagram that I showed you. So basically, you pick the donor from a list. The donor goes through the IVF process. We harvest her eggs, and we basically create the embryos. So we call those fresh eggs. The alternative is to actually pick eggs that have already been harvested and frozen. And this option actually is relatively new because the technology of freezing eggs is relatively young. In the past, there was a big advantage in using fresh eggs over frozen eggs. Nowadays, that advantage I would say, is very minor. So being able to actually use frozen eggs, again, widens your choices and allows you to lower the cost by actually choosing to purchase a lower number of eggs. So again, when we have our discussion, our conversation, talking about the egg donors, that's one of the things that we discuss in detail, is what is the right thing for you to do. And finally, the uterus, and I will spend just a little bit of time because Melissa will fill you in on the surrogacy side. But of course, if you're using your own uterus, we make sure that it's normal. We do the testing to verify that everything is all right. When surrogates, basically, we use for same-sex male couples or for heterosexual couples where there is a problem with the uterus, either missing or dysfunctional, or in cases where the woman's medical condition doesn't allow her to become pregnant. And, medical condition is a very broad term. Sometimes it's a life-threatening condition that basically puts her life at risk if she becomes pregnant. But sometimes there are women who basically have, just concerns, anxiety about being pregnant. And that's also a very legitimate reason to choose a surrogate. Similar to the donors, we want to pick, healthy women. Of course, the profile of a surrogate is very, very different from an egg donor. The surrogate has to have children. That's the condition to become a surrogate. That way, we can actually go back and look at her history, pregnancies, deliveries. We actually check very carefully her medical records and contact her physician just to make sure that they're comfortable with her becoming pregnant again. That's a very important part of the screening of the surrogate. For age, interestingly, the age of the surrogate doesn't really matter very much. We have great success with young surrogates and older surrogates, preferably 44, but actually even that is just sort of a general guideline. We have surrogates that are in the mid-40s and 45, 46 who are excellent, excellent surrogates. So that's something that, again, is sometimes a little bit difficult for people to sort of accept, and again, something we will discuss in more detail. Of course, very, very important that the surrogate is healthy and has a good lifestyle. So we basically check all of that, her weight, her physical, mental health, non-smoker, negative drug screen, and making sure that she has a safe and stable home environment. As it is with the egg donors, with the surrogates as well, we want to make sure that their motivation is right and to make sure that they understand the responsibility of actually taking on this job, because it is a job. We want to make sure that they'll be compliant with whatever we tell them to do in order to maximize the chances of success. So when you start this journey, the surrogacy part of the journey, you will go to to see Melissa first. And they will talk to you and explain and ask you a million questions. And after a while, they will find the right match, the surrogate that they think is a good match for you. And based on the surrogate's profile, which you will review, and if you agree that she's a good match, then we get all of her medical records and review and make sure that she's okay. So again, pregnancies, deliveries, C-section, any complication, compliance, all those things we check to see which hospital she delivers, how far the hospital is from her home, and what happens if there is a complication that requires a higher level center for her to go to. And if we're satisfied with all of that, then we will bring her to our office for an in-person assessment. Again, very important. And when she comes in, we do the medical evaluation, physical exam, ultrasound, infectious disease, and also we do the psychological assessment. So similar to the egg donor, we actually spend quite a bit of time on the psychological assessment of the surrogates, because again, it's a big responsibility to take on. In addition, different from the donor, they usually have a family, they have their own children. We want to make sure that everyone in their support system is on the same page. During their visit in the office, I very highly recommend that the surrogate and the parents get together. Again, for Europeans, people who live far away, we can do it online. We can do it on Skype or Zoom. But it's just very important that you meet, you get a good feel of who the surrogate is, We have our counselor, our psychological counselor, who actually facilitates the meetings, which sometimes, for the first time can be a little bit awkward. And just make sure that everyone is happy. In other words, you like the surrogate, she likes you, we think it's a good match. And if everything is good, then we will send you to the agency to finish all the legal arrangements before we move on to the contract. I zoomed in on this slide and I can't get out of it. Carolyn, I need your help.
Yes, of course. I am right here. Which slide do we need? Is this one?
Oh, here we go. Yeah, thank you. That's perfect. Yes. So basically, just a summary of what I just said. The agency will present you with a candidate. We do the review. We bring her to the office. We go back to the agency to do the contract, and then we can schedule the embryo transfer. Just as far as the timeline is concerned, usually we start with the sperm. For most people, finding an egg donor or making their own embryo with their own eggs comes next, which means that by the time we find a surrogate, then we're essentially ready to do the embryo transfer as soon as the legal contract is signed. Just very quickly, and actually this slide is a little bit out of order. The same is true for egg donors, is true for surrogates as well. Because for people basically intuitively feel that if you look for someone who's done it before, who's familiar with the process, who'd had a baby through surrogacy before, that woman would make a better surrogate than someone who's doing it for the first time. And the reason I have this slide here is to tell you that that's, we'll give the pun, it's a misconception. In fact, we have very clear data to show that there is no difference in the success. So first-time surrogate, proven surrogate, have the same chance of success. And there's really no reason to actually narrow your search to those women who've done it before. And that way you can actually find a surrogate quite a bit quicker. So I think that I will stop here so I can leave a little time for Melissa to speak as well. And as I said, I mean, Melissa will introduce herself, but for me, it's always a pleasure to work with Melissa and an honor, because Melissa is actually one of the pioneers in the field of what we call reproductive law in the US. And she started her own agency quite a few years ago, maybe 20 years ago or so, and we've been working together ever since. So I'm going to hand over the screen to Melissa.
Excellent. Thank you so much, Dr. Levy, for your presentation. And of course, yes, now it is time for Melissa's presentation. So, Melissa, are you ready to start as well?
Yes, I am. Thank you. And thank you, Dr. Levy, for the wonderful introduction. Yes, we've been working together for 20 years. And it's excellent to be able to work with a facility that also has egg donors, so that when you come to the United States, you only have to go to our office, because we have the agency and we also have a legal department, and New England Fertility, because if you need an egg donor, they also have their own egg bank. So you don't have to have as many facilities, which for people from abroad can be very confusing. So as Dr. Levy said, my name is Melissa Brisman, and I have been practicing in this area for about 20 years. I founded an agency, Reproductive Possibilities, 20 years ago, and we've had about 2,500 babies through surrogacy. I myself had all of my kids through gestational surrogacy. And today we're going to talk about the U.S. experience. So we only have 20 minutes, so there isn't going to be a way for us to get in depth in everything. But today we are going to talk about the advantages of coming to the United States, a little bit about the legal process, how we screen a carrier besides medically, how much it costs, which is a pretty, how long it takes, and also how many times you have to be in the United States for it. So as you won't be able to get all of your questions answered, you'll be able to go back to the screen and you can see all of our contact information here for our legal team and our agency. You can visit our websites, you can send us emails, you can look at our social media if you have any questions. In case you are viewing this, not live, but seeing it as a taped version, you should know that this is not legal advice, that we are not right now attorneys. This is general. You really do need to call us and have a consultation if you want legal advice for your specific circumstances. So basically, why would you want to come to the United States instead of another country? Why do most people come here? So in the United States, the legal process is extremely regulated. Basically, what does that mean? That means here, surrogacy which is with of a person other than the person carrying, what we call gestational surrogacy, is legal but enforceable. So in most states, and we only work in the states where the surrogate cannot keep the baby. So with proper legal advice, that baby will automatically be yours when it's born. We also have some of the best medical technology, which means that if you want the best chances of success, we want you to come to the United States. There are some countries where the number of embryos produced is very low, the stage of the embryo, the testing that they'll be able to do, the PGT testing is available here. And here in the United States, you also have a lot of choice. Not only is surrogacy legal, but you can do it for any reason. So for instance, you can do it for a medical reason. You could do it because you have advanced maternal age. You can do it just because you want to do it. You can do it if you're a same-sex couple. You can choose the number of babies you want to have. You can choose the sex of the babies. So you have a lot more choice here in the United States. If you would like the carrier to have an abortion and she is in agreement of that, you can have abortions also legally here for lots of different reasons. So what do you need to use a gestational carrier? So you need certain elements, obviously, right? So we need a surrogate, right? We need an embryo. So you don't actually have to ever be physically present in the United States except to pick up your baby, but we will need the embryo created. So you'll either have to ship that embryo here or come to the United States to make that embryo in a clinic like Dr. Levy. You'll need a lawyer, which we have in our agency. I am a lawyer, and we do have other lawyers. You will need a psychologist, which will be on staff at the clinic. And you will need an agency like we have to help you find the carrier. So how do you simplify this? This is what I was talking about in the beginning. You have so many elements. You want to get as many of those elements in one place as you can. So you want to have a one-stop shop. So you want to have an agency that can do everything except for the medical. So for instance, our agency has legal, escrow, and finds the carriers all in one place. You also want a clinic like New England Fertility that has worked with gestational carriers and foreign clients before. If they've worked with foreign clients before, they'll be able to do a lot of things over Zoom. They'll be able to reduce the number of times that you have to come to the United States, which again is very important. So the key things that you should be aware of when you're doing a gestational surrogacy, the biggest thing is the timing of the arrangement. Most people come over to the United States and they want to know, can they have a baby in 9 months? So normally this takes about 1.5 years. It's going to take us about 6 months to find the carrier and then a couple of months to get her ready. It does cost if you are using your own eggs, it's a little bit less, but if you are using an egg donor, you should expect this to cost somewhere between $100,000 and $150,000 US dollars. So you have to be prepared that this is going to cost some money. You have to also be prepared that it's emotionally difficult. So we do have support groups and counseling. There is medical risk, so we want the carrier to be aware of those. There is minimal legal risk in the United States, but we will go over that with you as well. And there are insurance issues. We need to make sure that the baby is insured, that the surrogate mother is insured. This is an element that we go over greatly during the process. So step one, when we find a carrier for you, that's the first step of the process. We want to know, A, that you can make embryos if you want to use your own eggs. So I want you to see Dr. Levy to make sure you can create your own embryos. And then B, I want to find a carrier. I need to know what is important to you. So for instance, if you want a carrier to abort for a birth defect, I need to make sure that the carrier will do that. If you don't want to, if you are from England, let's say, and you don't really want to travel all the way to California, you only want a carrier on the East Coast, I need to know that. I need to know if costs are an issue for you, because if you want a carrier that is less expensive, I need to find somebody who maybe has their own insurance or doesn't have a job outside of being a carrier, is a stay-at-home mom, so there's not too many lost wages and things of that matter I will need to look into. I want to know if you want a carrier that you're going to have a cordial relationship with or a friendship. So, you know, some carriers want parents who are going to be super involved and be on a more friendly basis, and some carriers are fine with, you know, a cordial relationship. You check in with them, you make sure they're okay, but it's less of a friendship. I also need to know if you have insurance in the United States. So if you are an outside resident, I need to make sure that that baby is insured, and that is a complexity that I need to go over when you're coming from abroad. At the same time as we are looking for a carrier, just so that we can stay on that 1.5 year timeline, I want you to work with a clinic to make your embryos, whether it's with your own gametes or donor gametes. And there are things that I'm going to want you to think about. I want to know, do you want to sex select? So that would be, you would have to make sure that your physician or New England Fertility knew that you wanted the PGT testing. You have to go over with your physician the risk of single or double embryo transfer. Most people, especially from abroad, want to have only one baby at a time, because if you have 2 babies, you could get stuck here for a long time and have costs involved if the babies are in the NICU at all. However, that's something that will be up to you and the physician, so you need to talk to Dr. Levy about that. Newborn care is not usually covered for foreign clients. So if you have a child in the United States and the twins have a very long hospital stay, that's going to increase the cost, something we need to go over. I also want you to go over with the clinic how long you need to be present. For our purposes, you need to be present in the United States once that baby is born. And assuming there's no pandemic or extraordinary travel measures going on, you're usually here for 2 to 4 weeks after the birth of the baby. Right now, that is increasing to 6 to 8 weeks with the passport issues, but in the past, it's been 2 to 4. Then, once we've identified a carrier for you, I want you to meet with the carrier via a phone call or video call. We will be on the phone with you, someone from the agency. We want to make sure that you're on the same page about a lot of big issues, that your feelings about how the pregnancy will go, how the delivery are on par. And then once that's done, we have to get her screened. So Dr. Levy explained that you have to do a medical screening, which would involve him looking at the medical records of your carrier, making sure it's safe for her to have another baby and that there were no extreme complications in her last pregnancy. There will be a psychological meeting. Our office will make sure a criminal background check is done on the carrier and her partner or her husband, and also a home study on the home to make sure it's a safe place to live, that, you know, that she takes care of her kids well, and that in generally it's the type of home environment that we feel comfortable with a pregnant woman residing. After that is all complete, there will be a clinic day at the clinic where the medical testing is done and the psychological, but there will also be drug, alcohol, and nicotine testing on the carrier and her husband and partner. If she has a partner that she's living with, we will also do it on the partner. There are administrative aspects as well that we want to do on a carrier arrangement. So we need to make sure the carrier has health insurance, and I review it and make sure it's good and will cover a surrogate pregnancy. I need to make sure the escrow account is funded so I could pay the carrier. I'm also going to make sure that you have a contract with your carrier. Make sure all those legal issues are spelled out. Where is she going to deliver? Are you going to be in the delivery room? Is she going to pump her breast milk? Is she going to abort? Is she going to reduce? And then I'm going to need to go to court to make sure the intended parent or parents are the sole parent or parents on that birth certificate and the carrier has no rights. That's called a birth order. So I'm going to need to do that between 3 and 5 months of pregnancy. When I'm doing the matching process with your carrier, I'm only going to match you with a carrier in a state not only where surrogacy is allowed, but which is okay for your particular circumstances that you will be placed on the birth certificate. So basically, for instance, Tennessee does not allow birth orders for people using an egg donor. So I would only get you a carrier in Tennessee if you were using your own gametes. If there was any chance that you were going to go to a third-party egg donor, no carriers in Tennessee. So that is important for us to be up on the law in all the states and the different parameters. And again, plan to be in the birth 2 to 6 weeks after birth. I mean, in the United States after birth, excuse me. So when I'm picking the carrier, what's going to matter the most? It's going to matter where the carrier resides, gives birth, and where the parents live. All of those are going to be important. So during that process, I'm going to look at all of those and see if the law can be utilized during that process. Factors to consider when we look at the law are, I'm going to need to look at where the egg is coming from, where the sperm is coming from. Is it a donated embryo? I need to know the marital status of the parents. I also need to know the sexual orientation, if they're single or married. All of this is important, and the different states will have different laws based on all of these factors. Once I have all this information, I will be able to consider the best state for the particular person and the particular gamete being used. There are 50 states in the United States, and each state has a different law. And so you will be matched based on your marital status, the gametes, and the states. So we need to pick which state law is best for you. When we are doing the contract, I also need to make sure that not only am I representing the parents, but the carrier has her own attorney. That's very important. The contract may not be enforceable if a carrier doesn't have her own representation. If she doesn't know somebody who specializes in this area of the law, we will help her find somebody. There are organizations out there for reproductive law attorneys to join, and we can get somebody from one of those organizations. Now, what are you going to cover in your contract? So you want to have certain things and make sure that they're in your contract. You want to make sure abortion and reduction, whatever your views are. You want to make sure payments, receipts, what does the carrier get reimbursed for? What's her own responsibility? You want to make sure you talk about confidentiality, the use of social media. Can she post anything about you on social media? Can she talk about you to family and friends? What can she reveal to people? You want to talk about how you're going to contact. Is it going to be over Zoom? Is it going to be over Skype? Is it going to be by FaceTime? You want to know, is she going to let you in the delivery room? Is she going to pump her breast milk? All of this will be in the contract. Once the contract is completed and her lawyer has gone over and it's negotiated, the funds will be escrowed to pay the carrier. This is for 2 reasons: to make sure the carrier can be paid, and also to protect the parents, that receipts are examined and that the financial aspects are left to the agency, so that if there is an issue where the carrier needs to be pressed on financial issues, that the parents don't have to be involved. Also, our escrow funds are fully insured. You want to make sure any agency uses insures their escrow funds from theft from employees or hacking, which is something very important. Then, once all of that is done, you go to the procedure and hopefully your carrier is pregnant. Most carriers will agree to 4 embryo transfers. Hopefully by the 1st or 2nd, she'll be pregnant. That's when we get a birth order. If there is only one parent, it's called a sole parent order. We like to get these orders before birth. We will tell you certain states do them after birth. Certain countries like Israel require the birth to be done post-birth. So we want to make sure that we're doing the order correctly, so for immigration purposes, you can safely to your home country and get citizenship for your baby. Also, we want to make sure that we look into the fact of whether or not you're going to possibly use an egg donor. So as I said, when you pick a carrier, the state laws vary if an egg donor is going to be used. So I want to pick the carrier not based on if you're planning on using your eggs, but also if there's some possibility in the future you might use an egg donor. Then I want to pick a carrier that's good for an egg donor, because in that case, if you switch to donor eggs, I won't have to get you a new carrier. Egg donors in the United States can be known or what we call as not identified, meaning that all egg donors will eventually be able to be identified now for what we have at-home DNA kits that you could get. But you can have a donor that is not identified, who doesn't know that who you are, and you don't know who they are, but you can also meet your donor if you want. And New England Fertility does have donors that are willing to meet if that's something that you want. So basically, what do you need to know in the beginning? The two big things you need to know is having a guide and being thorough is a key to successful journey. You want to make sure that all the parts are there, and that matching, screening, legal, and escrow are all parts to a gestational carrier arrangement. So I will take some questions now, as well as Dr. B. I also want you to know that this is a lot to get in just 20 minutes. So if you have more questions or you want a full consultation, both of us will give you that for free, and you can just contact our office.
And excellent. Thank you so much again, also, Melissa, for a very interesting presentation, for all the details. And yes, now it is time for your questions. So again, let me just remind everyone that you can type those questions in the chat section, and Melissa and Dr. Levy will be happy to help you out. I am very, very sure about this. So there are a few questions ready. So, okay, Melissa, Dr. Levy, ready for them?
Yes, we're
Yes.
ready.
Excellent. Okay. So this is the first question. I am 41 with 4 failed IUIs and 1 IVF with abnormal embryos, and I'm thinking of moving forward with an egg donor. I had an MRI to check my uterus because of possible adenomyosis. I don't have the results yet. If I have this, does this mean I cannot carry? Is miscarriage a concern? And thank you for your question, of course.
Sure. Thank you for your question. So, as far as using a donor as opposed to continuing to try on your own, that's always sort of a very difficult decision to make, of course. But it sounds as if, for me, I mean, you've done the IUIs, you've done 1 IVF with normal embryos. I mean, it sounds as if egg donation is probably the right choice. And again, as long as the uterus is normal, the success with an egg donor is very, very high. Now, in your case, of course, we have to actually take the issue of adenomyosis into consideration. Adenomyosis is one of those conditions that is sometimes really, really difficult to know if it actually affects the chances of success. Typically, adenomyosis actually is a disease of women, or a condition that women develop after having a baby. So having adenomyosis in someone who has not been pregnant or has not had a full-term pregnancy is somewhat unusual. And it really depends on the severity and the extent of the condition. So the condition essentially is a situation where the glands that are normally on the surface, on the lining of the uterus, for some reason grow into the muscle. And that can create symptoms, pain, heavy bleeding, and in some severe cases can affect fertility. So the MRI is probably the good first step, but if the MRI looks reasonably normal, if the adenomyosis is not very severe, there's some additional testing that you can have, that one can have, to look at the function of the uterus, not just the structure. And those tests, are sometimes require what's called an endometrial biopsy, where you take a sample of the lining. And with those tests, you can actually tell if the uterus is not only structurally normal, but also functionally normal. And if it is, then it's definitely worth a try. And if there is a question, it's probably because it's such a big step to take, and it involves significant costs and emotional investment. sometimes surrogacy is the right answer.
And thank you so much for answering this very first question and for your advice on this as well. And well, now let's have a look. Okay, there is another question. Ready? So you mentioned freezing sperm. Is the sperm used to create embryos from the same sample as FDA test sample, or is the sperm used to create embryos a different sample collected at the time of egg retrieval?
So basically, the requirement from the FDA is the testing be done on the same sample or at the same time as that the sample is collected. So it is a blood sample that we send to the lab, and it's a sperm sample that we freeze. So ideally, they both need to be done at the same time. What we've done with international clients, international couples, is that we will send you the kit. It's a small box with some test tubes, and when you give the sample for freezing, you can have some blood drawn, and that blood is processed and sent directly to the FDA lab in the US. So we have quite a bit of experience with that, and we can point you in the right direction to find a clinic that's willing to freeze the sperm, collect the blood, and help with the shipping. So we've been successful with this for many different countries, and not just Europe and Hong Kong and Israel and India. So it's certainly possible, and especially nowadays, saving a trip abroad can make a huge difference in the process.
All right, excellent. Once again, thank you so much for your question, and Dr. Lavi for your assistance with this question as well. Okay, next question is here as well. I do receive this quite a lot, so that's why I have put that here. So, is there an age limit for intended parents to be able to go ahead with surrogacy in the US?
So in the United States, there is no legal age limit. So if you could find someone to treat you at any age, they can. However, most clinics and agencies will have certain limits. The average is in the 50s. Our agency doesn't like to treat clients unless there is one partner under 60 in the relationship. So basically 59 and a half is our age limit. We do let people use the same surrogate again if they're over that age limit for a sibling. But in general, you can technically be any age, but I think once you hit the 60s, you're going to have some difficulty finding somebody.
All right, excellent. Thank you so much, Melissa, for clarification to this question as well. Thank you. All right, let's have a look. Next question is also ready. So, do you work with any with agency or multiple agencies to find surrogates, or is that something you do in-house?
Okay, so I'm the founder of the agency Reproductive Possibilities. So we are finding our own surrogates for all our clients. And as I said at the beginning, we've had 2,500 plus births since inception. So that is done in-house. We do have a team of 20 working on finding the carriers and coordinating all the aspects.
All right, excellent. Once more, thank you so much for your question as well as your help with this. Okay, next question is right here. Hi, Dr. Lavi. What is your opinion on sending a donor's frozen eggs to a clinic with all the difficulties of travel and quarantine, not to mention a lot of extra expenses? Having the oocytes frozen and then defrosted have a lower percentage survival rate. Do you think it would be better to ship embryos to have them transferred to the surrogate?
Yes, thank you, Angela, for the question. It's a good question because, as I mentioned, freezing eggs is a relatively new technology. Freezing embryos has been around for a very long time, and it's a pretty standard procedure. The technology we use now for both embryos and sperm and eggs is called vitrification. The problem is that the eggs have actually been sort of a little bit late to the game because the egg cell is the most difficult cell to freeze. Much more difficult than sperm and more difficult than embryos. So the answer, from our experience in our laboratory, we get the same success with frozen eggs as we do with frozen embryos. However, it's, for me, it's always a little bit of a dilemma to say, okay, you can send me your frozen eggs from whatever clinic, and we will create the embryos here, because again, I need to know a little bit more about the lab where the embryos were created, their success, their experience, their exact technology. So the simple answer is yes, if you're going to ship, is if the option is to ship eggs or embryos, I'd rather you ship the embryos. So I'd rather they created the embryos, because that way we can be much more comfortable that what we end up getting when we thaw is going to be a viable. So the simple answer is embryos is better than eggs, but of course it has to be done on an individual case basis.
All right, excellent. Again, thank you so much, for your question, and Dr. Lavi for your advice on that as well. So someone is typing, so I just want to see. But oh yeah, sorry, we do have another question, so let me go to that. I am 42 to 43 with one failed IVF and fibroid removed. I still want to try with my own eggs. Can I?
Yes, you can. The thing about, basically, success of IVF, as you all know, I'm sure, the success goes down with age. Usually goes down with age because of the woman's age, and the reason it goes down is more to do with the eggs than with the uterus. So, assuming that the fibroid surgery was successful and the uterus is structurally and functionally normal, then it comes to the question of what are the likelihood that someone who's 42 or 43 can actually create a genetically normal embryo. And in fact, that's why I'm a very strong believer in doing the PGS, the genetic testing of embryos, because then you know for sure that you have an embryo that's viable. So what we know from experience, again, statistics, is that when you're 42 or 43, most of your embryos you produce are genetically abnormal, over 90%. So, of course, it's possible that you will generate a genetically normal embryo, but you may need to do IVF a number of times, and it may never happen. But again, if you're going to do IVF, and you're in your 40s, I really think that doing PGS is important, because, and not just doing PGS, but also, as I mentioned earlier, growing the embryos to the blastocyst stage, because then you know for sure that what you have is really viable. So, for example, doing a transfer on the second or third day after fertilization is not really enough time to be able to properly evaluate, assess the embryos. And even if the embryo does grow to day 5 and becomes a beautiful blastocyst, there's still a fairly high probability at 42 or 43 that it will be genetically abnormal. So, you have to basically know what you're getting into when you say, I'd like to try with my own eggs. But and I understand that using an egg donor, it's a huge step. It's a huge decision, one that you don't want to take lightly. So it may be worthwhile to try, but you want to avoid this, there's a trend to do another one and another one and another one, doing the transfer on day 2 and day 3, and the embryos look good, but it doesn't work, or there's a miscarriage. So yes, it's a sort of a complex answer, but yes, it's possible.
All right, excellent. Once again, huge thank you for all those different options, of course, as well. And well, let me have a look. There's another question that we again receive quite often when it comes to surrogacy. So let me show you. So, do you offer any live birth guarantee programs when it comes to surrogacy, of course?
So we both offer package deals. So our company does have a package that you can get multiple surrogates if it doesn't work. We can't guarantee you that a baby will come out, but we will offer you a very large number of tries with different surrogates. So we do have those programs available.
All right, excellent. Thank you for confirming this as well. This is definitely something that is worth to remember. That's for sure. Next question will be for Dr. Levy. Okay, so let me show you the details. So, two failed IUIs. Is it better to do a third one or to take egg donation? Additional information: single nearly 42 FSH, 20 AMH 0.002. Sorry, 0.002. Sorry.
So, well, basically with these values, so it's not just your age; it's more the values, the FSH, the AMH. So, with an FSH of 20 and a very low AMH, as I mentioned earlier, your chances of actually creating a genetically normal embryo are pretty low. I think your chances of having success with IVF are probably in the low single digits. So, so again, there's IUI, there's IVF with your own eggs, and there's egg donation. In my opinion, someone at your age with these numbers should not do IUIs and should think 2 or 3 times before they actually commit to IVF because of the chances being so low. So again, it's possible, and everyone is different in how they feel, and you have people that I think you need to understand what you getting yourself into, because there are people that I sit down and I say, okay, with all these things, you have a 2% chance or 3% chance of success, and some people would say, oh, that's better than zero, and let's do it. And for other people, it's not high enough to justify all the effort that goes into it. So it's a very individual decision, but objectively speaking, someone with this profile should use an egg donor.
All right. Thank you again for the clarification as well. And Mathilde, thank you for sharing this information and, of course, for your question. Okay, let's have a look. Next question is ready. Can I have a clue about the estimate price to use surrogacy with an egg donor?
So the price to do surrogacy, if you do everything in the United States, including the IVF, use the agency, find an egg donor through New England Fertility, is about 120 to 150 US dollars, $1,000. So 120,000 to 150,000, depending on various factors.
Mm-hmm. Okay. And can you tell us about different packages? So let's say if you have like two different ones, I mean.
We have two different packages. One is a premium package that guarantees you a certain number of surrogates. The price difference in those two packages is only going to be a few $1,000s. So it's not going to be what pushes you to the 120 versus 150 is really how many times it takes the carrier to get pregnant, not really the different packages that you have. Because even with the packages, let's say you have a package from both New England Fertility and our office, you still are going to have to pay for her travel to get to the clinic, her lost wages, her fee every time they get $500 every time they have an embryo transfer. If they have a miscarriage, they get certain payments. So it's really based on things that we can't estimate exactly, like whether or not she gets pregnant right away and whether or not there's a miscarriage in the beginning.
Oh, of course, excellent. Thank you so much for giving that estimate price. Of course, yes, this is definitely good to again remember. And well, let's have a look again. This is a question I did receive quite often from all the patients. So, what is the typical timeline to achieve pregnancy through surrogacy? So, how long does that can take?
Well, the actual cycle itself is pretty quick. It's, between 2 and 4 weeks, depending on, exactly where they are in the cycle, how much Lupron, whether or not they ovulate. But actually having a pregnant surrogate it's an 18-month process on average to have a baby. So usually by the time they start, it's about month 9 by the time they're pregnant. And then obviously there's 9 months towards delivery. So it's about 18 months to take home a baby.
All right, excellent. Thank you so much
And
again.
just if I can just add here too. So I think when you talk about the timeline, as I said, we do it in steps. And I think if you think of it as if you think of it that way, and you say, okay, well, we're ready to start, I suggest we do it sort of in a parallel track, meaning that get the sperm. That usually is first. find an egg donor if you need an egg donor. That usually takes a couple months. And as soon as we have the sperm and the eggs, we make the embryos. And that way, by the time we find a surrogate, because that usually takes a little bit longer than finding an egg donor, by the time we have a surrogate, we already have the embryos waiting. And that way we can move right away into the embryo transfer. So that's sort of, if someone is anxious to get it done as quickly as possible, that's the best way to approach it, as opposed to let's make the embryos, make sure we have embryos, and then start looking for the surrogate, because that's going to obviously make it a little bit longer.
Of course. Okay. Excellent. Thank you so much once again for the clarification. That doesn't sound too long when you are putting this in that way, of course. So thanks so much for clarification to this. Okay. Someone is typing. Okay. So I just want to see it. I need a minute. So let's wait and see the next question. We just need to wait a bit for
So
that.
I'll say a little bit about the last question while they were asking. People always ask me about the timeline, and also the timeline is when you start, right? So somebody will say, oh, I came to see you and it's taking me 2.5 years, but when they came for their consultation, they actually didn't fill out their paperwork or start making their embryos for a year, because obviously this is a lot to digest. So the timeline starts also when you actually start moving. It doesn't start from like the first time you see us. You have to actively start making your embryos and actively start working with our agency to select your carrier. So you have some control over the timeline. We can speed it up a little bit. We can slow it down a little bit. Like right now, some people are asking to take a break for a month or two until the travel restrictions are lifted. So that's reasonable as well.
Okay, excellent. Once again, thank you so much, Melissa, for that. Next question is right here for Dr. Levy. So let's have a look. I have a low AMH, but I would like to use an egg donor. What is the best to improve my AMH, or it doesn't matter, as I will use egg donor?
Well, it's actually simple. So first of all, there's no way to improve your AMH. The AMH really is not a problem. The AMH is only a marker. So the AMH essentially tells you what your ovarian reserve is, how many eggs you have, indirectly how many eggs you would get if you did IVF, and indirectly the quality of the eggs and the chances of success. So the AMH is not really a problem that you want to sort of fix. The AMH, the egg reserve, also does not have any impact on your chances of becoming pregnant when you use an egg donor. So when you have many women that have a low AMH still have normal cycles. But even if you don't, if your cycles are not normal, even if you have no cycles, it's still possible to create a cycle using hormones and still have exactly the same chance of success with IVF, with an egg donor.
All right. Again, thank you so much for your question and explaining this to us as well, Dr. Levy. Okay, let's have a look. Again, I have put a question that I have received quite often, and here's the question. So, what kind of counseling do you have available, and do you also offer any post surrogacy support?
So we have both available. So during the process, first, New England Fertility has counseling available on staff. That is who is going to screen your carrier. We also have a network of providers that we work with in addition to provide counseling. There is post-surrogacy support, especially more so for the surrogates than the intended parents, because usually the surrogates can sometimes suffer postpartum depression or when their hormones are fluctuating. So you will have lots and lots of support, both from the agency, the doctor's office, and the various counselors that both of us have on staff.
And again, thank you so much for that as well, and explaining everything. And let me have a look. For now, at least, I do not have any questions that I see. So we will be slowly finishing. However, if you have any questions left, you know what to do. Just type it in right now. So Dr. Levy or Melissa can help you out a bit. But of course, also in the meantime, let me just remind everyone that this has been recorded. You will have a chance to rewatch watch it, of course, within the next few days. It will be uploaded on our website. But also, we'll put here the links in a minute, so that if you would like to ask any other questions, either Melissa or Dr. Lavi, you will be able to simply those will be forwarded to them, and I'm sure they will be happy to help you out more in detail as well. And as Dr. Lavi has mentioned, consultations are also available, right? So I will put the links in a minute, but let me have a look. In the meantime, we did receive a question, so let me have a look. Has there been any registry yet regarding serial egg donors?
Yeah,
Not sure.
yeah,
Okay.
Yeah,
yeah.
Thank you.
yeah.
I think I understand the question. The big issue that we face both with egg donation and sperm donation as well is that there is no real control over how many times these donors can donate their genetic material. And of course, the solution would be to have a registry where, when you donate, whether it's sperm or your eggs, you're on the registry and you basically limit the number of times you donate and limit the number of eggs or sperm that are out there in the world from the same donor. Unfortunately, that does not exist. It does not exist in the US, and to my knowledge, doesn't exist elsewhere either. And it's sort of left to us, the providers, to have some kind of accountability or responsibility to make sure that that doesn't happen. And it is difficult. I mentioned the fact that we try to limit the number of donation within the country. Outside of the US, we try to limit the donation within the same state in the US. But that's sort of only, it's sort of something that we do on our own, and it's not required. But yeah, that would be great if one of those registries actually were created.
All right, excellent. Thank you so much for that question. Indeed, very interesting, but also thank you for clarifying this. Well, and actually, in the meantime, I have received this email, this question from one of the patients on the Instagram. So let me just send it to you. Just give me a second. Yeah, I think I have it. Okay. The question is, so what happens if something unexpected happens, like any medical complications or issues within the relationship? Of course, it's about the surrogacy. Are there any, let's say, I'm not sure how to say it exactly. So is it possible to have some sort of, I'm not sure how to say it,
Yeah,
guarantees?
no, I know what
Okay,
the person is trying to ask. So this is a lot of different questions wrapped up in one. So
of course.
your gestational carrier, if she has medical or surrogate, as we're referring to, if she has medical complications, she will have health insurance, and those medical complications will come under the health insurance, usually for up to 6 months after a miscarriage, birth, termination, and you will be responsible during that time for what we call in the United States copays. Those are usually minimal payments, but you will also have to keep her health insurance in place if you were paying for it. So all this will be covered in the contract to limit everybody's financial exposure. You're having insurance for this. After 6 months, this is a risk that the carrier takes. So if, for instance, she has a lifelong medical problem, that is not something that you will be expected to pay for. If the embryo does an implant, usually they agree to try up to 4 times, and that's obviously up to you and the physician if you think it's worth it to try again, like if there was issues with her lining. Most of the time, if the embryo does not implant, these women have gotten pregnant before, and usually the physician is going to think to try again. Obviously, if it doesn't work 4 times, you're going to change something, whether that be the egg, the sperm, or the carrier. So as far as issues with the relationship, that's what we have lawyers and psychologists and social workers to help you work through that. So there's always something unexpected. I've been doing this for 20 years, and I've been dealing with unexpected things all month due to the virus. So usually if you're at an experienced agency, we'll know how to, if it's unexpected, we'll know how to handle it. We won't know exactly, but we'll know where to go, what to do, if we have to contact the senator, the passport office. So we have to take things as they come sometimes.
Okay, excellent. Thank you so much for answering this question. And again, once more. And well, I guess we will be finishing. Okay, so already I would like to thank to all of you for joining us tonight for your questions. And as I've mentioned, the links that you can use if you would like to get in touch with Dr. Lavi and Melissa, those are right here in the chat section. But of course, there is an option to click on ask a question. This will be forwarded straight to both of them, of course. And well, as we will be finishing, I would like you to see that there are some thank yous from our patients to you for your support today as well. Dr. Levy, Melissa, is there anything else you would like to add?
No, I just tell people not to get too overwhelmed at the beginning because it's a lot of information we're throwing at you at once, and to just try to digest it, and the process will go along, and you don't have to remember every single thing that you're told in the beginning. It's going to be repeated a lot of times over the process.
All right. Thank you, Melissa. Dr. Levy?
Just to basically to Melissa's point, that the idea is that you understand the process, the idea that you trust us to do a good job for you, and we will, and we work together because it's, like I said, it's a team effort, and that allows you obviously to focus on the important decisions in the process, like picking a donor, picking a surrogate, and actually having sort of a good experience through the process, enjoying the process. So as Melissa says, it's a little bit overwhelming, even for those people who've done IVF before, who are familiar with the process, because there's so many moving parts, and obviously everything has to happen just right. But this is what we do. This is our thing, and this is what we do. Um, and so you just have to be comfortable with that. And I think the other issue for people who do it from another country is that it's hard enough to do it if you live nearby, but it's also very difficult to do if you're in another continent. And again, just with all the technology we have today, we will keep you very, very close to the process. And we're always, phone call, a video, email away from being able to give you answers in almost in real time.
Excellent.
So
Thank you so much, Dr. Lavi. That definitely sounds encouraging, that's for sure. So thank you so much, Melissa, Dr. Lavi, once more for joining us tonight, for your expertise and for sharing your expertise, and of course it's always a pleasure to have you here for sure. And I just want to mention that actually Melissa and Dr. Lavi will be back this Friday at 8 p.m. UK time. There is another topic they will be presenting, and it's LGBT, so your family building journey. So I can only encourage everyone to join us as well on Friday at 8 p.m. UK time. So once more, thank you all for joining. Remember, it has been recorded. You will find it on myivfanswers.com, and of course, if you simply go to our YouTube channel, that way you will know when the new video is uploaded, so you can subscribe, of course, to our YouTube channel. And as you know, we will be back tomorrow also at 6 p.m. UK time, at 8 p.m. UK time. I do hope you will be able to join us as well. Thank you all. Have a lovely evening. And Melissa, Dr. Lavi, have a lovely day, the rest of the
Thank
day.
you. Very nice to
And
meet everyone.
well, I will see
good to
you
be with
on
you.
Friday. Thank you so much.
Thank you.
Bye.
Bye bye.
Bye.